Hi, my name is Ginny Eliason, and my role is with the Health Information Technology team as the Stakeholder Engagement and Communications Manager. I want to thank everyone for joining us today. We're pleased to host an informal conversation with the leaders from Washington State's Healthcare Authority on the topic of Link for Health, Washington State's Medicaid Clinical Data Repository, and statewide electronic exchange of longitudinal clinical records. Today our panelists are Dorothy Teeter, the Director for the Healthcare Authority, Marianne Lindeblad, the Medicaid Director, Dr. Teresa Fotinos, our Deputy Chief Medical Officer, and Nathan Johnson, the Assistant Director for Healthcare Policy for Washington State. So let's get started with this conversation. We're going to host something that's informal, relaxed, and I'd like you to hear the leadership speak about what's important and why we're doing this project at this time. So let's open up the questions. The first thing we wanted to talk about, Dorothy, maybe you could start us out on this, and that is, why is the work important to the larger community, and why this strategy, and what's the importance of the timing now?
Thanks very much, Jenny. I think in answer to your question about why this work is important in the larger community is actually fundamental to this strategy. Increasingly, Washington State is recognized nationally as well as within the state itself of really leveraging health information technology and all that potential that holds for improving health, not only at the community level, but also at the individual level. So increasingly, we are hearing requests from communities as well as healthcare systems and providers to ask us to help them support the work that they need to do to achieve the three-part aim of better health, lower costs, and improved care experience for all the folks that they serve in their clinical practices, but also in the communities themselves. So as we move the healthcare system from facilities and doctors' offices out to the community and join our community partners, whether it's housing services or whether it's mental health services or it's our public health partners, we want to be able to share some of the information that we can to improve the health of populations as well as the individuals that reside within those in our communities. So it's an idea to me that as time has come, we've spent billions of dollars in this state, if you count it all up, on developing electronic health records. And now people are beginning to see that the potential from that investment now is able to be leveraged to really look across the state at the community level as well as at the individual level and how people are doing in terms of health improvement strategies and new and innovative ways to improve health. Why this strategy and why now? I think, as I said, it's an idea that's time has come with the current investments. It's time now to really push the state to the next level of not only innovation and care delivery, but also in terms of leveraging the investments that have been made. Improved interoperability across providers and access to the clinical data that we now have in various parts of the state in our delivery systems will greatly enhance our ability to achieve better health and better care, and ultimately at lower costs that we also want to achieve. We'll be able to now support with this new infrastructure what our state innovation plan calls for and what our governor is calling for in terms of pushing from purchasing for volume to purchasing for value in all of the work that we do. Healthcare Authority itself purchases care for, well over 1.5 million people, and to the extent that we have data that shows what's working and what isn't from a value-based perspective, we can move away from purchasing at a fee-for-service level and really incorporate this clinical data into our decisions about how we want to support our clinical providers in providing care in a different way. Equally important, I think, is the self-management tools that can come along with this investment, so you as a person, as a patient, can understand your own clinical data and join forces with physicians and others in your community to help improve your own health, as well as partner with your providers to improve your healthcare decisions that you make. And then lastly, I think, although this is a little bit more complicated perhaps, and I will emphasize before I say this, that privacy, security around all this data is ultimately the job number one, so that we protect people's individual privacy. But with a clinical data repository, we have the ability now to really look at population health status of every community in the state at micro levels as well as broad picture levels, to say, geez, if we really are intent on helping people stop smoking, for example, or stay active, eat more healthily so that they maintain a healthy weight, for example. We can all do that now with this data repository at that population level, that we can see if our strategies are working. So in short, it's an idea this time has come, and our providers, our public health system, and our community partners are ready to join with us to work with this data.
Dr. Fotinos, I'll ask you the next question, and that is, who really needs this, and who has asked for this? Who's expressed that there's a gap in what's available nowadays?
I think Dorothy spoke well to the higher system level needs and desires for this information. As a family practice physician, for years I have wished that I could have better information on my patients, particularly patients who had multiple complex needs and maybe got some of their care from a community mental health center, other pieces of their care from a chemical dependency center, and really not knowing what medications they may be on, what their issues were, how they were being handled. And for some folks who are particularly vulnerable, their ability to sort of gather and carry that information from place to place isn't really something that they're able to do, because their other priorities are having a roof over their head, getting enough to eat. And so to expect folks who aren't necessarily able to navigate their lives in the way that a lot of other people can, asking them to be responsible for that information really just puts more burden on them. So as a provider, having access to that information, if someone was in the emergency room last night, what were they seen for? What were they treated for? What medications did they give? That's a safety issue. It's also a stewardship issue. I don't want to repeat tests that someone just had a week before from another provider. I don't want to expose someone to the radiation of a CAT scan if they just had one a month ago. So it's a safety issue, it's a health issue, and from the patient perspective, I can tell you the number of times that I've heard patients say to me, why are you asking me these questions? The person at the front desk asked me these questions. When I went to the doctor last week, they asked me the questions. My social worker asked me these questions. The answers are the same. You people need to learn how to talk to each other, because I'm tired of telling my story. We shouldn't make people repeat themselves. So I think that from both a provider and a patient perspective, this is long overdue. I think that from a community perspective and a purchasing perspective and a health care system perspective, the time is now. I think we've needed this for a long time, and I'm excited that we're moving ahead with it, because I think it will absolutely help patient care, it will help providers, but ultimately it will help the health of our communities. And the other piece I would add as a bit of an extension to Dorothy's mention is that this will allow us to look at where populations are healthy and where they may not be, but it will also allow us to be able to, in particular, take a particular intervention and try it in a community, to Dorothy's point, to see if that works to help the patients in that community, and at a smaller level, the individuals. So I think everybody needs this, and I think that pretty much everyone involved in helping support the health of people have asked for it.
How does this relate to the innovation plan and Healthier Washington and the grant application in general that we're waiting for?
About a year and a half ago, the state launched in a roughly 8-month-long planning effort and created a state healthcare innovation plan out of it that sets the course for health reform in this state over the next 5 years, that builds on the construct of the Affordable Care Act, where we now have near universal access to affordable coverage for our community. What is the next steps we need to take to ensure that coverage is meaningful, to ensure people have access to health care and their health is ultimately being improved over time? This 8-month process gave us a great opportunity to engage over 1,100 people in this state, stakeholders from across the spectrum. You've heard of many of the actors already, and some of the comments Dorothy made earlier: providers, payers, the community, social supports, housing, faith-based communities, and others all came to the table to help us build out a vision for the next 5 years. That vision is further described in our grant application that is presently before the Center for Medicare and Medicaid Innovation. We've asked for just over $90 million, which would help us further the vision laid out in the innovation plan. Specifically within that plan, there are kind of, if you will, 3 cornerstone strategies. And I would argue at the outset that all 3 of these strategies rely on much better access to real-time, verifiable, accurate clinical data in the hands of the delivery system. The first one of those strategies is to move, as Dorothy has already indicated, the vast majority of healthcare that we purchase today on a volume basis, on a fee-for-service basis, to a value basis, that is paying more for the outcomes of that care than the actual widgets of care that are being provided. We'd like to see 80% of our state healthcare purchasing on that value-based continuum by the year 2019, 5 years or so from now. That is an ambitious task, and it's very hard to hold our delivery systems accountable, to hold our providers accountable, or our payers that we work very closely with, without their ability to access real-time data that allows them to manage at the point of care, ensuring that not just the widget of care is being delivered, but that person's health status is in fact being improved as a result of the intervention. So clinical data, access to it, interoperability of that data is absolutely essential in moving from volume-based to value-based purchasing of healthcare. Secondly, one of the key elements of the innovation plan, and especially focused on Medicaid, was the integration of physical and behavioral health services. And that is to say, right now we have a fairly bifurcated administration, financing, and delivery of those services to Medicaid clients that really splits people at the neck on down and the neck on up in terms of where they get their services and how they're managed. One of the key and critical elements for moving behavioral physical health integration forward is the ability of those providers to talk to each other, to share relevant clinical information about populations that they're caring for at the same time. In many cases, a behavioral health provider or a primary care provider may have no idea what prescriptions are being prescribed, may have no idea what type of interventions, MRIs or otherwise, that Teresa alluded to earlier, have been provided. And clinical data is an absolute essential element, and access to it for moving the integration of physical and behavioral health care forward, largely to achieve whole person care that is not so focused on how the state is organized, but more focused on how people's needs are organized. And finally, one of the key elements of the innovation plan is community empowerment and accountability, recognizing that improving health in our broader community is more than just engaging our health delivery system partners. It is more than just the money we use to purchase healthcare services. In some cases, it has a lot more to do with what's happening outside of the 4 walls of a healthcare institution, and how to allow communities representing multiple sectors, both inside the delivery system and outside of it, inclusive of public health, social supports and services, the faith-based community, and others that have a relevant stake in the overall health of the community and its improvement. How to engage them is a focus of the plan. One thing we know in engaging communities and multiple sectors with different focuses and different funding streams is they must have relevant and actionable data. Dorothy earlier alluded to how you can manage and look at population health through the prism of clinical data. None of that's really possible today, given the types of silos that store that data and make it very hard to access for that purpose. So whether you're talking about going from volume-based to value-based purchasing, whether you're talking about meaningfully integrating physical and behavioral health services at the point of care to serve whole people, or whether you're talking about empowering communities to a new level of accountability for population health, one common construct and element is necessary, and that is better access to clinical data, especially in the delivery system.
We are aware of the silos that take place currently today between physical care coordination and behavioral health and chemical dependency care coordination. Maybe, Marianne and Teresa, maybe you'd like to address how this effort will support better coordination and integration of the 2 types of care.
Sure. Our existing delivery system today is bifurcated. So for individuals with serious and persistent mental illness, folks with significant chemical dependency needs, their care is provided outside the managed care delivery system that currently supports the physical health of the individuals that we serve in the Medicaid program. And those systems don't talk to each other very well. And so the patients that are served by those systems, often the providers don't know what care they're getting in the system, or even if they're involved or engaged in the behavioral health system, as an example. Here's an opportunity to have and create the opportunity to share this kind of data, share this information so they know what care needs this individual has, what sort of social supports they need or are getting, so that the person is provided services. It is a whole person approach. It's whole person care. It's looking at what their needs are. There's research that supports individuals with significant mental illness die 25 years earlier than someone who doesn't have a mental illness with the same other chronic care conditions. And it isn't dying from their mental illness, it's dying from their diabetes or their heart failure or other chronic medical conditions. So this does create the opportunity to really have those two systems talking to each other, sharing information, knowing how to provide whole person care, and supporting that individual in the community structure that they reside in, and providing those other kinds of supports that individual may need to be successful in their healthcare journey. So this is a key component of the project that we're moving forward with between Department of Social Health Services and the Healthcare Authority in achieving full integration of physical and behavioral health by the year 2020. And we hope to have even some early adopter projects launched in 2016 that demonstrate our capacity to do this kind of full integration to better improve the healthcare outcomes of the people we serve. This being ability to share this data, it will be critical to the success of those efforts.
Yeah, I would just add a couple things, Marianne. One is that I think that we often hear this spoken about from the primary care perspective, that it would be really helpful to me as a primary care provider if I knew that a person was getting mental health care and had medications or was in treatment for a substance use disorder. I think the converse is true in that if someone is being seen in a mental health center, it's absolutely important that care team knows about that patient's diabetes or that person's heart disease, so that when they might exhibit symptoms, they have a baseline to go on, or that they can check in periodically and say, you're taking your medications for your mental health condition, how are your diabetes medicines going? They can be alert and redirect that person in the other way. And I think similarly for chemical dependency providers. I think one of the things this also has the potential to do, and I've talked to some of my peers who've been able to work in settings where there's integrated care, there is no going back. They feel so much better about the care they're able to provide their patients because it's a conversation now. It's not just them working in a vacuum with someone else working in a vacuum. It's a conversation, it's a shared interest, it's a shared goal, and they are very jazzed about it. And my hope is with this integration, it continues to move the conversation forward, that it's not just about chemical dependency treatment or mental health treatment or clinical medical treatment. It's about all three of those, and to wrap sort of the larger community and social supports around that, it becomes about health, as not so much health care, but all those pieces are needed to promote health. And so it moves the conversation forward in that way when you can share information and know that it benefits the person. So I see this really as both an imperative and a necessity to provide safe, quality care, but also to help move the conversation from one of let's treat people when they're really sick and most ill to how do we help prevent illness and recognize it before it happens. So I see this really as on that road to do both.
So Nathan, perhaps you could share a little bit about how this particular effort complements other data collection initiatives that are taking place across the state at this time.
In the conversation around the innovation plan and specifically moving health reform forward, it's become very clear that to get at value, you need actually two ends of the data spectrum. You need to understand about the quality of care and care improvement that's taking place. This is where especially clinical data can be most useful to be understood at more of almost that research level. The other critical component of the value proposition, though, as we look at healthcare authorities' role as a purchaser, is understanding what the underlying price being paid for that care is. And that price varies significantly across individual provider groups and delivery systems, and regionally as well. So one of the important data initiatives that's very much related to this is the state's effort to build and implement an all-payer claims database. House Bill 2572, passed in the 2014 legislative session, laid down the construct, the foundation for this work, and that work does continue in earnest. primarily led by our partners at the Office of Financial Management. The opportunity for synergy between clinical and claims or financial data sources is incredibly significant, because oftentimes for individual populations, for people, there are gaps in the care record for whatever reason. Perhaps a provider has not, in fact, leveraged an electronic health record system as of yet due to capacity issues. Perhaps something was missed on a claim. In fact, many clinical interventions that are made at a hospital or clinic setting are never recorded as a claim, at least not with enough detail to do anything about it. So the opportunity to mix and match and operate with the synergy of both financial and clinical information, both to understand better whether the value proposition is being reached and whether we are improving overall health for the populations we serve, but also even at the point of care where those interventions are the most necessary and the most timely. Having data sources served by both ends of the clinical and claims spectrum will be incredibly useful. And very, very specifically, to get after value-based purchasing, we understand from our delivery system partners especially that operating strictly from claims data, operating strictly with only the financial information at their disposal, at least at any population level, is incredibly restricting. No one wants to take on increased risk for the outcomes of populations without having a very, very deep understanding of both clinical interventions being made and the cost of those interventions overall. And these parallel data initiatives will greatly help us in that effort. And interestingly, at least in our state, they're timed very similarly, which allows each to learn quite a bit from the other. So that's quite encouraging.
One of the questions that always surfaces during a conversation like this is about privacy and security of clinical data for our clients and our patients. Teresa, how will this impact privacy and security of clinical data?
That's a good question, and I think maybe flipping that question a little bit is how can we assure the security and the privacy of information that people don't want shared, balanced with the information that different service providers, whether they're physical health, mental health, or chemical dependency, need to provide the most safe and best care for their patients. And I think Dorothy touched on it in her introductory remarks, that we have to assure that the information is secure and that privacy is maintained. And I think right now there are a lot of electronic health record systems out there, and they wouldn't be operating if they didn't have those controls in place. I think that the state is in somewhat of a unique position to help, if nothing else, provide some broad guidance as to here's how we interpret privacy and security and what that means, so that other institutions can say, well, the state sort of signed off on this piece, we can do it too, because as there are many different electronic health records, there are many different versions of security and privacy and what that means. I think that one of the key pieces of this is that people won't be given access to information that don't need it. As a clinical provider, I'll be able to see a person's medications, their health problems, potentially if they get permission across different domains, but the social worker who may need some of the information about that patient won't necessarily have access to that same information about medications or the person's medical problems. It'll really be role-based and what's necessary to know to help you provide whatever services you give. So I think that security and privacy are key to both pay attention to and make sure we do very well. One of the things that we will be addressing as we go forward is within the realm of treatment of people who have substance use disorders, there are some specific federal regulations that make the sharing of that information very much dependent on that patient's specific consent to do so. And so I think a lot of providers have interpreted that to mean that you can never talk about a patient's health issues as they relate to substance use disorders. So I think part of this is making sure that we protect and follow the regulations that are federally or state in place, but we also help educate people who may be over-interpreting some of the barriers or some of the current rules so that access to information that can be provided is shared in a way that best benefits the patient. So I see this as a priority in terms of the work that we need to do to assure this serves people best, but also to help educate people that some information is okay to exchange in our current environment and how best and most safely to do that. Would you add anything, Mary Ann?
This is such an important topic, and it's something that we are looking at very closely, particularly as it relates to behavioral health information. So working with our partners at the Department of Social and Health Services and others to find a way that provides that confidence from the individual that their information won't be shared inappropriately or inadvertently, but in a way that's done so the best and the highest quality care can be provided for them. So it does take a number of individuals to work these issues through to really make sure that we have a system in a way that shares information that helps provide that care but doesn't violate the wishes of the individual.
So one of the questions that usually comes up also has to do with cost and what are the costs associated with this. So Marianne, would you share a little bit about the approach and the strategy on the funding for this?
Actually, I think we've found a vehicle to start. So there's really a way to start this, so how it'll be initiated, and then sustainability over time. And because of the number of Medicaid patients or Medicaid individuals that we have in our state, over 1.6 million lives now are covered by Medicaid, and about 1.4 million lives are being served through our managed care plans. And given those numbers and the need for this ability to share this information and how it supports the providers that contract with our managed care plans, using our managed care plans as the vehicle to help support this seemed like a very logical way to go. So for a very small monetary investment on the part of the managed care plans, about $1.05 per member per year, that's the investment they make to support this initiative. So again, a rather small investment to provide data for them and for their providers to better serve the members that they serve. So we've been working closely with the plans to move this initiative forward. Now, it won't just be a Medicaid approach, but Medicaid, using Medicaid is a good place to start. And this will spread over time next to our public employees program. And then we certainly have interest from other health plans to look at how they could buy into this in the future. So we'll get it started next year with our MCOs, the Medicaid MCOs, and then expand as we're able to.
Thank you, everyone, for your participation.